Hello, everyone. Welcome to another episode on Blue Squad on Health. Today, I have the pleasure of inviting Dr. David Shulkin, who was the ninth Secretary of VA and who led the second largest federal agency in the United States during the Obama and Trump administration. And he effected substantial change in the VA, and we have the immense pleasure of talking to him today. Dr. Shulkin, welcome to the show.
I'm
Do
pleased to
you
be
want to
here.
give a few words?
No, glad to be here and glad to talk to you today.
Great, thank you. So, just to say that we are connected in a certain way, because I think you are on the board of Sanford Health
Yes,
at this stage. And we are the organization that delivers digital health solutions to the Sanford World Clinics.
fantastic.
In fact, yeah, we run their entire platform for Ghana and most recently the entire system in Costa Rica, where there are substantial hospitals and clinical systems.
Sure. I've visited there as part of
You have gone to
December.
Costa Rica.
Yes, sure.
Great. So, having said that, I think I have been watching some of the interviews that you have given, and many of the things relates to how you affected change and your views on the Veterans Affairs. And I was really pleasantly surprised that in your latest podcast, you did not go around and criticize it as another federal bureaucracy that doesn't get things done. And that was refreshing. Would you like to say something more about how that organization is truly contributing to the American way of life?
Well, when I entered government, at that time I was the CEO of a large private hospital system in New Jersey. And it was a time that there was actually a national crisis in the Department of Veteran Affairs back in 2014, what people often now call the wait time crisis, where a lot of veterans were returning from Iraq and Afghanistan with devastating injuries. Our Vietnam veterans were turning 75 and requiring a lot of healthcare services, and the VA was overwhelmed and clearly not succeeding in its mission. And that resulted in the resignation of the secretary at the time, the undersecretary. It was a national scandal in many senses. And when President Obama asked me to come in to try to help fix this, I basically thought, look, this system may be so broken that it may not be capable of being fixed. And the very best thing that I could do is to shut the system down, do it in an orderly fashion, but get the veterans into the private sector, the area that I knew the best, that I had been doing my whole career, and make sure that they got the right help. And when I got to the VA and I got to see the type of care that was being delivered, the mission that the organization had, the passion that the employees had for caring for veterans, I came up with the assessment that it was exactly the opposite, that the VA system was essential, that it couldn't be replicated by just simply sending veterans out into the community, that veterans would suffer that way. And so I felt a very strong commitment at that point to making sure that we could fix the system and make it sustainable for not only the current group of veterans, but those in the future, so that it would be there as a national resource.
And so this is kind of like saying we have all the right intentions, we are the right passion, but we don't have the right tools. And I think that's pretty much what you arrived at in terms of trying to push the new EHR system into the Veterans Affairs.
I think it's a little bit, I mean, that's certainly a fair assessment, but it's not just as simple as, making sure that the right tools are there. I think what I saw was a system that had been a very innovative system that had evolved and created new models of care, but had done it 20 years ago. And there had been a leader about 20 years ago of the health administration that had created new models of care, organized the system into regional networks and developed models of primary care, patient care homes, and the VA was very, very proud of that. But after about 20 years, the model got pretty stale and it needed a refreshing and it needed a fresh look at whether that system was still serving the needs of the patients and of the veterans in the way that it really needed to. And so I felt like, um, bringing in new technology and tools was certainly part of it, but it was really creating a new model of care and creating a new vision for this new generation of veterans and this new generation of employees who remain committed to the mission but needed to look at the world a little bit differently because healthcare had changed and people had changed during those last 20 years.
One of the theses that I am really passionate in promoting is that the the advancing healthcare landscape demands a certain kind of reset of care models or innovative care models. And the traditional systems do not allow that, right? And so I think what you said is true that the Vista, again, we were a big fan of Vista when I started my career 30 years ago. And 20 years ago, I was in the open source community. We all held Vista in very high esteem. It is a very open source system, but it is based on 1960s technology, right? And I think even major systems other than Vista still, I don't know if they are still doing it based on that mom's technology. And naturally, this couldn't adapt to the new and evolved landscape that has come, especially right now, if you're talking about the AI and the microservices technology and the distributed computing. It just cannot handle that, right? And so, one of my questions about that is bringing it all together, right? The Defense Department and the Vista together into one single system. How did you evaluate the wisdom in that in terms of wouldn't it become a single source of failure? And would it really become this leviathan that it becomes a, you know what I'm saying, it becomes inefficient as it tries to become nimble? Like you said, if you wanted to experiment with different models and all that.
Well, the decision that I made to move away from Vista to a single instance of an electronic health record, in this case, it was the Cerner Oracle system, was very controversial. And I recognize that. In fact, that was very much on my mind when I made this decision that this was not going to be widely applauded or accepted. But I felt like that was the job of leadership to make these types of decisions for the organization. And I should just go back and sort of reinforce one of the things that you said. When I came to the VA, I came, as I mentioned, from working in private hospitals and, leading them. But I've always practiced medicine. I'm a primary care physician and internist. And I'd always said, I hope I'm the last doctor in America to use an electronic health record. I had no interest in it. I liked my pen and paper, and I really wasn't planning on changing. But when I got to the VA, even though I was leading the health system, I would always put on a white coat and stethoscope and care for veterans. When I got to the VA, there was no option for pen and paper. I had to use an electronic health record. So I had to start using Vista. And I have to tell you, I liked Vista. It was very usable, it worked well. And I understand why the doctors and nurses and other people in the system wanted to keep Vista. It made sense. But when I ultimately made this decision to move away from it, I was looking at the factors that the average clinician just didn't have the same sort of perspective that I had, which is this system sustainable? Can we really get mumps programmers? Can we keep up with the type of technology changes that were beginning to happen and were clear to me were going to happen in the future? Are we able to share information, interoperability with the Department of Defense? And I knew that every future customer was coming from one place, and that was the Department of Defense. And if we couldn't effectively communicate and share data, that was not going to allow us to do our jobs properly. But probably even most important, that I don't think that people who work in the VA, and certainly those who are outside the VA, do not appreciate. People talked about Vista as being one electronic health record for the VA. In fact, that's not true. There were 120 different instances of Vista. Each medical center over these past 20 years that I talked about was able to change and evolve and edit and adapt their own instance in the way that met their needs. That's why so many clinicians really liked it, because they said, I want it to look this way if I practice in Phoenix, and I want it to look this way if I practice in Boston. And they were able to adapt it. But that isn't where healthcare had gone in the last 20 years. We had developed health systems that began to understand that standardizing care, reducing variation, improving quality, becoming a learning organization, working in an integrated fashion was the way that modern medicine was headed. And the VA was not headed in that direction. So, for all those reasons, I made an assessment that we could not continue on Vista. I did not make that lightly. Now, I'm going to add one additional factor so that you can understand about how I made this decision. I went back in history and looked at why did the Department of Defense 10 years earlier move away from their own electronic record system called MHS Genesis and move towards a commercial system, in their case, Cerner? And how often had people described their intent to bring the Department of Defense and the Department of Veteran Affairs into a single system together? And I went back, and it had been over 20 years that Congress had been calling for this, that other leaders had been calling for this, but it just never happened. And therefore, if the Department of Defense 10 years earlier had picked Vista as their system, it's possible that together we could have evolved that system into a modern system. But they didn't. They chose a commercial system. So that really said to me we needed to be able to make that type of change. And I wasn't going to go through committee structures and calls for action. But as the leader of the organization, I was going to make that decision for the Department of Veteran Affairs, that we were going to move that system towards the same system that the Department of Defense
Don't mistake me, but I was not questioning the rationale behind going into that thing. I was just talking about the immensity or the scale of that implementation being substantial, right? And because of that, I was just wondering how it would go. But again, I don't want to continue to push that line, and I want to talk more about the future. And so much of our audience, so I was living in DC. In fact, this is a painting of Georgetown, if you recognize it. So I moved from DC to Switzerland. So I have a lot of people in Europe who are really fascinated by the American healthcare system, right?
had.
You have the VA system that is kind of like the NHS, which is government controlled and all
Yes.
that, alongside the private sector. And they would kind of like to understand how this thing works from a very simplistic point of view. And that is one of the things that I wanted to talk to you about. But before going into that, you said you came into that VA at a time of
Yes.
crisis, the waiting time. And part of our process in the patient engagement side, I would like to know, how did you effectively reduce that wait time? What were those particular levers that you had to pull to make that wait time lower?
Yeah.
Would you be able to?
Sure.
Yeah.
Well, the first thing that I had to do was to assess the situation and determine if there was really a problem. And I was able to, by using the significant data resources at VA, quickly understand what the problem was. And the problem was that we were treating all appointments, all access to healthcare, as if they were equal. So the first thing that I did was I made the VA change the way that they categorize their appointments to either urgent clinical needs or routine clinical needs. And that helped put clarity on the situation so that we're doing what a health system should do, which is to prioritize those that need the help the most to ensure adequate access and make sure that those that have routine needs have access, but they're not in the same timely fashion. So once we were able to change the way that we were viewing the system, it was very clear to me what we needed to do. The second thing that I did as the leader is I determined a new standard, and that new standard was same day appointments. That if somebody had an urgent clinical need, they were going to be seen the same day, whether it was a physical or a behavioral health care urgent need. And that put clarity on the system for the 400,000 employees about what their job was and what that standard was going to be. Previously, that had been a 30-day standard. And as a doctor, I don't know how to manage my schedule within 30 days. I just know I have a patient in front of me. They either need to be seen now or they don't. And so that clarity helped. Once we had that, then I used specific tactics. One of them was I granted full practice authority to advanced practice nurses and pharmacists so that we could begin to start having additional experienced healthcare professionals begin to take some of the workload off of our primary care doctors and other doctors. That made a big
Like nurse
difference.
practitioners.
Yep. Secondly, I rapidly expanded telehealth, and that required some regulatory changes that actually we got across the country so that we could begin to start using our workforce who had capacity in one part of the country to help other parts of the country. Prior to that, there were regulatory barriers, but I was a federal agency head, so I had what was called federal supremacy, where I could go above the state levels and change those regulations. There were a number of other tactics that we used to be able to, get this done. We shortened some wait time appointments, and we did what were called sprints in the medical centers where they would deal with those that had clinical urgent needs first. And finally, we opened up what's called the community care system, which is when veterans weren't able to be seen in a timely fashion, we made it easier and finally permanent law that they have the right and the ability to go and to see doctors or hospitals or other professionals in the private sector.
Interesting. Shahzad, if you have something, raise your hand. Okay. Well, this is a very interesting conversation. I could just keep going on. I have follow up after follow up questions, right? So, one of the things that I had this thing is I know my research is basically the VA is spending approximately $13,000 to $15,000 per patient. That is the approximate budget that I saw on my research. And so I'm sure when it is a government mandated, service that is being provided, there would, even though not explicitly, there would be principles of value-based care, cost to outcome. And I know that there is, value-based purchasing programs and other things. Can you tell me your experience in value-based care delivery models within VA?
Yeah. Well, this is one of the areas that VA fell behind in this 20-year gap of relooking at its model that I've talked about. The VA essentially works in a very different type of reimbursement system. I would go to Congress and I would say, we're going to care for 10 million veterans, and I need so many billions of dollars, several $100 billion to take care of this population. And Congress would give that money to the VA, and then we would determine the best way that that money be spent to care for those veterans. But internally, while most employees are salaried, they're not paid, or there's no incentive system like a value based system. When veterans go outside into the private system, they're paid on a fee for service basis. And that is legislatively required on the Medicare fee schedule. One of the things that I asked Congress for when I was secretary was the ability to start being able to do value based payments. I obviously knew that this was happening in the commercial sector, in the private hospitals. I had been running value based models before I went into the VA. And I knew that wherever VA was falling further apart from the private sector, that was going to put VA at risk of being a sustainable organization. So I asked Congress for that ability. They were somewhat skeptical about whether this was really just a way of privatizing the VA, which Congress appropriately was concerned about. So they opened up the door, but only a little bit, to be able to do some experimenting and piloting. More recently, in the Elizabeth Dole Act that passed at the end of 2020 became law, there was additional abilities for VA to begin to start piloting value-based care. So the VA is at the very early stages of implementing value-based models. It is an ideal environment, in my experience and my perspective, for VA to be doing value based care because of the way that it delivers care, its integrated model. But it is just really putting its toe in the water with the changes in reimbursement that, frankly, have been going on outside the VA for decades.
Even outside the VA, Dr. Shulkin, it's not that, it has not become that mainstream. Now, even when we are going and, people are implementing our digital health solution, we focus on value-based care, but the what I say is there is the metrics that needs to be analyzed, outcome and all that, and then there is the implementation of the care model, which is basically operations, and that most of the people who are using the system are not using the system for operational efficiency, and that's one of the things that I have seen, and we are trying to improve that. But the reason I brought up value based care is with regard to that wait times, right? Now, in terms of value based care, it would be a factor, is about how accessible was your healthcare. And also, that leads me to the question about preventative care, right? My feeling, I may not be right in this, is that VA has not been really effective in this preventive care that could actually reduce the per member expense. In other words, before they reach the hospital, you can do all the things that you could do. And can you elaborate on that in terms of the preventative measures
Yeah.
VA is doing
Yeah.
or not doing?
Yeah. No, I don't. I agree with you about that. In the private sector, value based care is still on the periphery, it's on the margins. There are some models, obviously, that, in the ACO models and at the full risk models that groups are doing, where it's become a central feature. But the vast majority of American healthcare is still in the traditional fee for service system. No question about that. In terms of the VA, though, my assessment is quite different than yours. The VA puts extensive efforts into prevention and extensive efforts into primary care coordination. And in fact, since the VA does not have the shackles of the traditional reimbursement system that the rest of healthcare has, in other words, it doesn't have third party payers creating the rules of what they will pay and won't pay for, the VA is able to invest much more heavily in population health strategies, in preventative care, in integrative medicine approaches like integrating behavioral health with physical health. And so that's really where VA, I think, shows extreme innovation and leadership for the rest of the country in how populations of health should be cared for.
Thank you for informing me about that, Shahzad. You were biting at chomping at the bit. That's what I was looking for, the phrase.
So, doctor, there's the private model and then there is the public model, right? So you have the NHS model or the VA model where doctors are aligned to give best care to the patient, right? And then you have the private model where that's the underlying factor, but again, the delivery model is not really concentrating on the health of the patient. There can be other business models involved. According to you, because you've started off in private practice and then moved into a model in VA, I would believe that the passion on the public model for the providers to provide the best care that they can give to the patient is more aligned in the public model, be it the VA or NHS. So what actually holds them back from being efficient in the real sense? Is it an outlook? Is it a strategy challenge in regards to, for example, the wait times? What really drives the inefficiency to come in if all the folks are passionate about giving the right care? Or is it fundamentally policy on how it works? So, what are your thoughts on that?
I wouldn't necessarily agree that the VA is inherently inefficient. It does not, this is a very complex topic. You know, when I first started practicing medicine, we had a lot more time to spend with our patients. Then with the changes in reimbursement and the impact of cost control, particularly that third-party payers imposed, the time that we could spend with patients started shrinking. And so, if you're a primary care doctor and you now have 15-minute appointments with patients who have multiple chronic illnesses, yes, you could say that's efficient. I can see a lot more patients a day. But is that the best way to care for complex patients? And is that the best way that we should be running healthcare? So yes, you can develop an efficient system by shortening times, by putting more people through the system. But as we've talked about, the VA doesn't view its job that way. The VA has very complex patients. Many of them have severe behavioral health care issues as well as physical health care issues, many chronic conditions. People have had complex injuries like traumatic brain injuries and spinal cord injuries. And we have not developed a system that says, let's go for maximal efficiency. Rather, the VA is trying to meet its mission of caring for those that have been injured during their service to the country. So, efficiency, of course, is important. And there are many efficiency gains that could happen in the VA. Some of these related to getting VA the right tools and technology, the right models of care, the right incentives. Absolutely. But I'm not aiming, or at least I was not aiming, leading the VA to make it similar or identical or match the efficiency of the private sector because it has a very different population it cares for and a very different mission. And of course, the VA's job is not to make money, it's not profit like many of our private sector organizations and health plans. The job is to care for those who have served.
Now, no, of course, what you said is true, but I'm thinking more about it's not about to make money, but to make every dollar go far
Yes,
further, right?
yes,
That is essentially what we are looking at it in
of
VA.
course.
Now, you have been the CEO of Beth Israel, then you were in Morristown
Hmm.
in New Jersey, and then right now you are in Sanford Board, and I also saw you in Paradigm again. A fun fact, we just lost a bit with Paradigm. We were through the all process, we were in the final shortlist, and we just lost this thing. So either you are all over the healthcare landscape, so wherever we go, we encounter one of your companies. The point I'm trying to ask is, in all these organizations and after leaving the
Hmm.
government service, do you see a push towards value-based care in any of the organizations that you're seeing? Or is there a deliberate resistance to moving away from fee for service?
There clearly there clearly is a strong resistance to move away. Else it wouldn't be this hard and taking this long and this many decades of people, especially leaders, saying that they believe in value-based care, but then their organizations really aren't behaving that way. And so yes, this has been a very difficult problem. And the assessment that I have about why it's so hard to see this change in the American healthcare system is because we are so siloed in the way that we deliver care. Health plans look at their perspectives one way, provider systems look at it another way, device companies, life science companies, technology companies all have different incentives, all have different business models. And in order to make a change in healthcare, you have to have an alignment of all these interests. And we really haven't had that. And so the only way that I see that really happening is through government, is essentially for government to have a clear policy and direction about where healthcare is going to go. And what we're seeing right now, as we're speaking during a time of government shutdown that is largely being positioned as a healthcare issue, is quite frankly that neither the Republicans or the Democrats have a plan that is going to impact healthcare costs or improve healthcare quality. We are not seeing a plan. We're seeing political arguments being made. We're seeing pricing arguments or cost arguments being made about why people are acting in a certain way. But there is no comprehensive plan being delivered or even suggested that would change the way that we deliver healthcare, the way that we pay for healthcare, the way that we access healthcare.
Secretary Kennedy has been talking, and in fact, my son is a big Kennedy fan, as all youngsters are. Right, he's 30 years old, and he's saying, Papa, he's talking about value-based care. He even during the Senate, when he was called to the Senate for reporting, he was talking about value-based care. He's trying to push for value-based care, and we thought it's really happening. But at the same time, like you said, government is making a concerted effort towards that. In fact, Medicare is pushing substantial amounts towards value-based care, isn't it?
Well, I think that there's been some statements to suggest that. The statement that all Americans who are in the Medicare system will be in a value based model by 2030 is certainly a very important and big statement. We're already almost entering 2026, and I'm not sure I see the elements of a path that would really get us there in 4 years. So I
It,
do believe that there have been some of the right types of leadership statements, but I'm not sure that I see the plans being built out, the proposals being discussed to change the American healthcare system from where we are now to being truly driven in a value based model is more than a 4 year journey.
yes, at least. Go ahead. Sorry.
Yeah, and just to add to that, connecting the dots of Dr. David, you mentioning our different stakeholders have different incentives. There's patient, provider is on giving care, and then there is payers who have different things. So, do you think, especially now, like there has been report that many of the hospital systems are now moving away from Medicare Advantage health plans from United Health or Humana because due to prior authorization delays and etc. But on the other side, we see, especially from the star ratings, the model like Kaiser, which has a very integrative care, has been performing quite well on the star ratings. So, do you think that an integrative model like VA or Kaiser would be the best way forward for value-based care implementation?
Yeah, look, I think what we're seeing right now, particularly with so many of the health plans struggling with Medicare Advantage and then pulling out of markets. So there are pretty good estimates that we may actually see a shrinkage in the Medicare Advantage population this next year. What that really says, it reinforces what I've been talking about, that pricing and access and reimbursement are all handled differently. And as soon as the pricing or the cost of these systems becomes so that people cannot make money in these systems, they just simply pull out. So there's not a true commitment to a specific model of care. This is one of these silos, and that's pricing, driving the type of care that's going to be offered to Americans. I think that when you look at a more integrated system, like the VA, like Kaiser, there is much more of a longer term commitment to the continuity of care for the populations that they serve. And I think that it's not a matter of one system is good and another system is not good, or that, for-profit health plans or for-profit healthcare is bad and not-for-profit is good. I think these are overly simplistic concepts, but I think we have to look at the principles of what needs to be in place to effectively deliver healthcare. And one of those is continuity of care. One of those is good care coordination. And one of those is to be able to benefit from the long-term investments that one system makes. That if you focus on prevention or you focus on chronic illness management, that that patient's going to be in your system, or that you're going to be able to benefit from those investments years down the road. So this idea of portability of healthcare models is important. And I think that what I've really been saying during our discussion is that it is time to reevaluate the way that we deliver healthcare in this country. And just like I talked about, the VA was 20 years behind. The last comprehensive healthcare reform in this country was 2009 when Obamacare came in. Now, you can argue now that we're in almost 2026, that model's good, that model's bad, there's problems with it. There's almost certainly truth in any perspective that you have on this. But the world has changed a lot since 2009, and it's time to take what we've learned during these last, 15 years to be able to propose a new model of how we deliver care for the next couple decades.
And what would that be? What would that learning for you have been in that 15 years?
Yeah, look, I've talked about some of these elements. There needs to be a alignment between clinical and financial systems in the country. There needs to be an ability to be able to have portability of healthcare across health systems, both with data but also with financial models. There needs to be the ability to do proactive population health care that includes prevention, but it includes the integration of various services and models of care. And there needs to be a reimbursement system that rewards for outcomes. So those are the key elements.
Right. Now, this fee for service model is so popular. I mean, it's a 3.5 trillion, I suppose, of the economy, the healthcare system, I suppose, right? And it's very difficult to change that. And even in Europe, it's the same thing. We were debating about, doing some solutions for Switzerland. And there also, there's no incentive for the insurance companies to change the business model. They're happy with what is going on. They know what the doctors do. The doctors submit the claim, they pay it, and they're fine with it. The doctors don't have an incentive to change it. So what you said is true. Until the government comes in and says, this is how the model needs to be, things are not going to change. And everywhere, including in India, where I am from, and in the global delivery center where my company is, there are about 7 or 8 super specialty hospitals within a 10-kilometer radius. And even though the rates are substantially cheap, it's still fee for service, right? Everywhere. And this whole model has not changed. Having said that, I want to take us to the current AI onslaught, if you will. Now, I know that there are 380,000 employees for VA. And do you think the government is going to implement many of these AI models or agents that can really reduce the reliance on so many people or make it much more efficient? For instance, getting the appointments and fixing the appointments. And I know for a fact that your decision to move to Cerner was now on retrospect as a well advised one, because Cerner is on the forefront of implementing ambient listening. They're coming out with an EHR that is going to be substantially AI reliant, and so it could perhaps improve the efficiency. So would that be would that be in line with the government thinking about implementing AI within the governmental organizations? Do you see the effectiveness of
I
that?
think that the elements of moving this electronic health record over to a commercial system, in this case Oracle, allows the government to finally begin to stay up and to be able to change with all of these new rapidly moving technologies. If the VA had continued to operate under the belief that it internally needed to develop and manage these systems, I do believe that would be harder to be able to keep up with these changes. But even in the example of the electronic health record, where there are 120 different instances and 173 different medical centers. Remember, VA has only implemented this system in 6 of them so far. So we're looking at many years still before all the system is switched over. And then when it's switched over to Oracle, it is not the AI driven model. Now, there has been a recent commitment of Oracle to eventually make sure that VA does have their newest AI driven model, but it's not implementing that model right now. It's got to get this base EMR in place, and then it will go back and look at these types of updates. So I think when you're looking at a system as large as the VA, it is going to take a while for it to continue to evolve and change and bring in these new technologies. Having said that, I do believe that there is a new philosophy that government should look towards outsourcing or working with technology vendors that focus on these types of issues. It will continue to identify what those right technologies are. I know there's a bunch of work being done in ambient dictation and other things, but it's going to take a while. And I suspect that the private sector will probably move faster.
All right. One of the luxuries is inviting somebody to the podcast is you can get one-on-one time, and I could go on and on. And I know you have pressing time, so I'll wrap this up. I mean, lots of questions and lots of queries that we need to ask. But do you have any closing remarks, Dr. Shulkin?
No, I appreciate your interest. I appreciate everything that you guys continue to do for systems like Sanford that obviously are very important. And thank you for having me on today.
It was our pleasure entirely. And this is our interview with Dr. Shulkin, a physician executive, much more than a secretary. He has contributed substantially. I know that he's a military brat. You were born in a base. Your father was in the military. Your grandfather was in the military. A true patriot. Thank you for your service. And thank you for joining us in our podcast today.
Glad to be here. Thanks so much.